if we could go around and just, if you wouldn't mind saying who you are and where you're calling in from, that would be very helpful so we can make sure that we get you credit for listening in on today's session.
Doorbell off.
Well, here in the conference room so far, we have myself, Francine Caffey with Pete's Pulmonary, and
Michelle Harkins, Adult Pulmonary,
and
Kevin Worling, Systems Analyst.
Aldine
What do we have
Domer.
out there?
I'm sorry, could you speak up? We didn't hear you.
I'm Aldine Domer from Rio Rancho.
From Rio Rancho. Thank you.
Hello?
Anybody?
Yes.
Hi.
Hello. Hi.
Oh, it said I had to call this to get the audio, but do I if I'm watching on my computer?
I don't know. I'm watching on the computer too.
Yeah, you should be getting audio through your telephone, and the video should be going through your computer.
Oh, so you have to stay on the phone the whole time? Okay.
You do, yeah.
Oh.
And who's that speaking?
This is Patty Jones. I'm the school nurse over at Cleveland Middle School.
Ah,
Not sure I'm going to be able to hang with this being on the phone.
Oh dear.
Hello.
Well, as long as you can. Hi there.
Hi. This is Alice.
Hey, Alice.
Is this Michelle?
Yes, hello. How are
Hi.
you?
And is that Alice?
Fine.
Burles?
How are you?
Yes.
Uh-huh. Very good. Welcome.
Am I going to be able to see you or not? Just hear you.
Just hear and see the slides.
Slides. Okay. Good.
You should be able
I'm
to
ready.
see the slides. Thank you for calling in.
Oh, my pleasure.
She's so nice. Anyone else? All right. Well, we'll check in after the talk and see who else is signed on. In the meantime,
All right. Thank you for inviting me to talk. We have our, please mute and unmute your telephone by pressing *#. And don't place your phone on hold. And again, you've already announced your name to get your CME credit. These are my disclosures. I don't have any disclosures. This is disclosures for the UNM CME policy. And Molina Healthcare Partners with Envision. You can get paid to get a free consult with us. And so eligible ones are overweight medical management, pediatric nutrition, telepsych, school-based health center providers, behavioral health conference, and of course our asthma pulmonary telehealth clinic. For specifics, contact Clancy Tarbox through the Envision site here. And coming soon, Blue Cross Blue Shield Salute Partners. We'll also get a level 4 reimbursement rate per claim. So excellent. And again, all the same eligible Envision clinics are there. Okay, we already talked about mute and unmute. All right, so I just wanted to talk a little bit about the goals of asthma therapy, tell you overall what we did at UNM to kind of decrease our ER visits, go through a case of asthma exacerbation and all the different treatments that are possible, as well as what we've now done to help decrease recurrent visits or repeat visits back to the ER with respiratory therapy run asthma education and self-management clinic. So the goals of asthma therapy are to prevent chronic and troublesome symptoms, maintain near normal or normal pulmonary functions, maintain normal activities, prevent recurrent exacerbations, provide optimal pharmacotherapy, and really meet the patient and the family's expectations. And this is from the National Asthma Education Prevention Program Expert Panel. So these are our lofty goals, and I think what we want to do in meeting some of the some of the patient and families' expectations, we really need to provide a lot of education. Education is really key for our partnership in asthma care, and so one of the things that we've done through UNM is teach the national guidelines to different physician groups, providers groups, nurses, respiratory therapies, and patients. That's really the key issue to get them to buy into the therapy plan. So we provide education and diagnosis, and really continually to all members of the treatment team. The other goal from the expert panel is to teach asthma self-management and skills for how they use their meds, teach them what about the medications and basic facts about their disease. And that's going to come in key to how we get them to decrease their healthcare utilization. And to provide a written action plan for all asthmatics when they come through. So at UNM, what we looked at back in, this is actually 1999, we looked at all the problems of asthma care in our institution. One, there was really poor adherence to the national guidelines by our physicians for standard treatment. There were very frequent outpatient visits, and this costs a lot for a select group of patients. And so what we thought we could do is provide patient education and follow up with an asthma educator, and then provide provider education. The other problems with asthma care at UNM, which I'm sure is applicable to a lot of places, is access to providers. So getting them into either primary or a specialty issue is an issue because we don't have a lot of providers. There were, again, many frequent outpatient visits and costs for several patients that weren't really captured into our pulmonary system. We also had other issues. So we want to provide peak flow meters, and we wanted to give patients spacers and teaching packs, and that really wasn't available in our clinic system. So we really worked with our central supply folks to be able to give out free peak flow meters, effective spacers, and teaching information packs. Pharmacy was only providing spacers to a certain group of patients, and there really isn't an intermediate treatment area. You either go to the ER or you suffer at home and then try to get into the clinics. But we didn't really have an intermediate area where you could kind of see people in an urgent care system. We do have an urgent care now, but that was not the case back in '99. So we looked at frequent utilizers of the ER and urgent care and outpatient clinic visits, and found several patients had more than 4 visits a year. In fact, one patient had 42 visits a year for asthma. So this is looking at asthma patients where that's coded in the diagnosis. And you can see that 115 patients in this graph had 4 visits for asthma that year. And it didn't go up hopefully as many, but 46 had 10 to 19 visits for asthma per year. And like I mentioned, the one had 42 visits. So outrageous number of visits for asthma, and these were for urgent type visits, not just your routine care. And when we looked at the cost of this, almost half of these patients were uninsured. So the patients that had more than 4 encounters per year, almost half, so 42% were uninsured patients. So that's a big burden, not only to the uninsured people, but even the insured patients that had several visits a year. Maybe some of these could be prevented and be a health savings. So we anticipated if in the medicine clinics we could cut some of the costs, in the ER we could really decrease their costs and really have a good impact. And this is based on the Loveless Health System asthma encounter data. Assuming that if we could cut some of these visits, we'd have a big cost savings to the institution. So we decided we would start an adult asthma care clinic. 1, to improve patient care, to improve implementation of the national asthma guidelines, and to really decrease the outpatient visits, and mostly the ER visits. Our ER visits then were about $500 at least per patient. Now they're about $890. And so if we could really decrease the overall cost in the institution, that would be a worthy goal. And we could also integrate our asthma care with our research aims of the university. So the patients that we wanted referred clearly were those that were intubated in the ICU. We went to a variety of physician groups and provider groups and kind of gave our pitch of send us your patients with severe symptoms. We want people that have been to the ER at least 3 times a year, and people that have been hospitalized, or if there's any question about the diagnosis. So we tried to go around to different healthcare groups as well as different providers to say, send us your patients that you're not sure about, and we can try to see if we can make a difference in their management. So we had 2 physicians, and we had a certified asthma educator who then became a nurse practitioner, actually, to help us with this. And we also had a lot of support from the university by having respiratory therapists that are in our clinic to do spirometry each time, but also to help with some of the education and making sure patients knew how to take their medications. The main thing that we had was a pager system for patients to get real-time answers and help. That was a little bit of a dilemma because they went off all the time, but patients need help when they need help. And so if you could give them advice, tell them what to do over the phone, see if they really need to come in or not, that might keep them from just automatically going to the emergency department. We also had a dedicated phone line, and our MAs in clinic would text page us if there was an issue, and we could make a decision whether we see the patient, treat them as an outpatient, or just help them work through their questions that they might have. So in our first year of clinic, so we invited all of our frequent flyers in the ED. We invited about 50 patients that had had more than 4 visits that had come through the emergency department. And pre-clinic, we looked at the number of visits that year before. For this select group of only 50 patients, they had 175 encounters. And then after we invited them to the asthma clinic and started taking care of them, there were only about 50 visits that next year for this group. So really decreasing the number of ER visits for these patients. Of course, there were, if you looked at all these visits, there are after hours visits, of course, when we're not necessarily answering the page, although they did call at 4 a.m. and midnight for refills and things like that. But after hours, there's always going to be an issue with patients that need emergent care. So still, we made a big impact on the frequency of the ER visits. This graph just kind of goes from 1999. The total number of ER visits was about 2,300. And it dropped off dramatically. I've only recorded 2003 where there were about 600 visits. This last year we have sustained a 50% at least decrease in ER visits. And even this last year in 2012, there were only 429 visits for asthma for adults. This is all adult data. So something has happened that we've been able to decrease and keep a decrease in asthma visits for the emergency department. So in our first year, the first patient group, we decreased the ER visits by 71% in that first year. Overall, ED visits have been decreased by 50% or so, and we have really improved access to care. We use drug programs such as the frequent or the industry free meds, so GlaxoSmithKline, for example, and other things. We helped fill out the paperwork. We gave them spacers and peak flow meters, so they didn't have to go to a separate place. They could also then demonstrate how they could take their medications if we gave them spacers, and how they could do peak flow monitoring if indicated. We gave them action plans, and we put them in the EMR, our electronic medical record, and obviously we had this asthma pager. This is just a copy of our asthma action plan. It is templated into our EMR so that if they come back to the ED, they know what their best peak flow reading is. They know what meds they're on in case the patient doesn't remember. And so handing them this action plan really helped, and we got the primary care folks to start using this as well. And then, we had phone numbers to call and a pager number to call to get advice on what to do if the patient is in their yellow zone when they're starting to have more problems. Okay, so let's just talk about asthma exacerbation briefly. We have a lot of pharmacotherapy for asthma. We have short-acting beta agonists, long-acting beta agonists. Inhaled steroids are bolded because they are the mainstay care for patients with persistent disease. They should be on an inhaled steroid. Leukotriene modifiers are also a controller medication. We have combination inhalers for asthma. There are 3 out on the market now. Theophylline is still being used. I don't particularly use it in adults just because of side effects and interactions, and it worsens reflux. And then, of course, oral steroids that we use for exacerbations, or in some patients, they may need to be on this on a daily basis. I don't have very many of those patients, fortunately. And then omalizumab or Xolair is a anti-IgE, so it's a monoclonal antibody to counteract IgE, so that those allergic asthmatics may have better control. This is sub-Q injection every 2 to 4 weeks. Super expensive. I don't have a lot of people on it, probably about $20,000 a year or so. So that's just some of our pharmacotherapy that we have in asthma for routine management. Now, when a patient has an asthma exacerbation, obviously it can be a variety of things that trigger it, whether it's allergens. Respiratory viral infections are probably the most common trigger. About 50% of asthma exacerbations are due to upper respiratory infection. Occupational agents, important in adults, not so much in children. Aspirin can be a trigger, not common in every asthmatic, but it is something that that we ask about as far as this being a trigger for an asthma flare. I have about 4 or 5 patients that have aspirin as their significant trigger. And in fact, I found one patient recently. She started taking over-the-counter cold medications every time she got a cold, and then some ibuprofen, and then she would end up in the ER with an asthma exacerbation. And so when you really kind of asked her, each time she got a URI, she went and got over-the-counter meds. So you have to talk to patients if you do think they have an aspirin sensitivity. They also cannot really take non-steroidal medicines such as Motrin, etc., or ibuprofen, and many over-the-counter medications actually have an aspirin derivative in it, so they have to be very careful. Sulfites, food preservatives, irritants like smoke, and then of course exercise and stress. So lots of things can cause an asthma flare. And when you have an initial evaluation of a patient with an asthma exacerbation, obtaining an FEV1 is preferred. I don't do that when patients are in extremis, obviously, but that's kind of the preferred measure. But a peak expiratory flow measure is important as well, and it could be an indicator for the severity of their exacerbation. You all know that predicted values are determined by nomograms, by age, height, and gender. There are lower percentage numbers for the patients that are Hispanic and even African Americans. You want to ask the patient their best value. And if a patient presents with an asthma exacerbation with their peak flow that's less than 30% of their predicted, and they don't have much of a change, less than 10% change after a bronchodilator, that suggests this patient has an increased risk of a life-threatening deterioration. So knowing kind of some of what their baseline function is, whether it's a peak flow or FEV1, if it's 30% or less, that's a big concern, and you want to watch that patient closely. And then, of course, pulse oximetry, if you have that available, that hypoxia may be a late finding. The patients that you really are concerned about dying from their disease is, again, are identified, some of the factors that are identified by the expert panel. So prior intubation, that is the number one risk factor for death from future death from asthma. Prior ICU admission, history of sudden severe exacerbations, frequent visits to the ER or hospital admissions. So that's why we wanted to capture those folks, because obviously their disease is not under good control. If you're using oral steroids, that's obviously a marker of severe disease, or you've had a recent exacerbation and on a taper, that might be a problem. Frequent use of beta agonists, comorbid illness, illicit drug use, urban area, lack of a written asthma action plan is also a risk factor. And then sensitivity to mold, and there are other things, psych disorders, etc., but these are just some of the risk factors. So assessing the risk factor for fatal asthma in your patient population, so the major risk factor, if you have a major risk factor present, then you might want to assume that this patient has a high risk of having a bad outcome. So, recently history of poor controlled asthma. So nocturnal awakenings, increased dyspnea, wheezing, increased use of beta agonists, maybe increased variability of peak flows if the patient is following them. And then a prior history, like I mentioned, that's the biggest risk factor, that endotracheal intubation and mechanical ventilation. There are several minor risk factors that could be present that might suggest the patient is in a higher risk category. And you can kind of read all those if they're elderly, they're smoking, the aspirin sensitivity, air allergen exposure, illicit drug use, and numerous hospitalizations, etc. So figuring out some of the major risk factors would be important so that you can kind of put that into your head. So if someone does come for an asthma exacerbation, I don't really get a chest x-ray unless there's something different. So unexplained chest pain, for example, if it doesn't make sense, really take a deep breath, it's very painful. You might suspect a pneumothorax or a pneumomediastinum, where you get air around in the mediastinum because of their exacerbation and hyperinflation. Maybe if they have sub-Q emphysema, so you're feeling and they have sub-Q emphysema, then that suggests that they might have a pneumothorax. So not common, less than 2% of patients that present with asthma exacerbation, but still that might be something to consider. If you think they have hypoxemia, leukocytosis and temperature, if you think they have a pneumonia, unilateral findings, especially in children, because they put things in their mouths, and maybe this wheezing and etc. is actually they've got something interbronchially. That can be also in adults that may have a tumor or something in the bronchus. If your patient is immunosuppressed, it's not unreasonable to get a chest x-ray, and then of course if they end up intubated on mechanical ventilation, they're going to get a chest x-ray. And even in the outpatient setting, I don't typically get chest x-rays on patients with asthma unless there's something, I look for prior ones, but I may not get that unless things don't seem to follow appropriate treatment course. I don't know, Francine, what you guys do in peds, but...
not usually.
Yeah. So there's not really a strong indication to get one as an outpatient or even necessarily as an inpatient, but... for some of these findings or some of these concerns, you might want to consider that. I don't get arterial blood gases very often in the outpatient setting, clearly, but in an inpatient setting, if you have someone coming to the emergency department, hypercapnia or hypercarbia is seen when your peak flow is less than 30% of predicted, or FEV1 less than 30% of their predicted. And so if they come in and they're in severe distress, or things they don't seem to be turning around with your aggressive nebulizer treatments, etc., then it might be reasonable to get a blood gas. And a normal PCO2 is not normal in someone with an asthma exacerbation because they are breathing to beat the band, and so they would breathe off all of their CO2 and have a low CO2. So as the CO2 starts to rise, then that's a sign that they're getting fatigued and can be very worrisome. Remember that actually that albuterol can induce a lactic acidosis, so that might make your pH look strange on your blood gas, but it's not a respiratory problem. Okay, so you've come in with an asthma exacerbation. We know that giving early steroids helps decrease the risk of hospital admission and relapse. Oral and IV is probably equal efficacy. I give IV usually when they first come in, especially in the ICU, and then switch to oral medications. It doesn't really matter. Probably not more than 60 milligrams is key. You don't have to give 80, 100, 120. That's probably a good dose. You can also give IM steroids, and we've done that in some of our asthma patients in clinic that have come in with exacerbation that you don't think they're going to pick up their steroids. Then you might want to, you could give it intramuscularly. So here's a case. So the 47-year-old woman presents with asthma. She's in obvious respiratory distress. She's not febrile, but she's tachycardic. She's hypertensive, blood pressure 193/116. And she gets put on a non-rebreather mask, as everyone does in our institution when they come in with asthma. And so her SATs are okay. And she's breathing about 28 times a minute. She has audible wheezing in all lung fields, and she responds with one-word answer. So what are kind of the initial treatments that you use for an asthma exacerbation? So you kind of want to just think about what we do for patients. Typically, we give them albuterol. And our protocol in the ER is to give 5 milligram nebulizers every 20 minutes times 3. We also can add ipratropium to that neb, especially if the patient comes in a lot of respiratory distress. You can use them, short-acting beta agonists and these short-acting muscarinic agonists, the albuterol and ipratropium, via an MDI and a spacer. Just have to give more puffs, and the patient has to be able to do the maneuver while being watched by the respiratory therapist. Most of our folks get just nebs. And the patient's going to think that that's the best for them anyway, because that's what helps them. So we give them nebs. And we give steroids if they're not responding to that first neb. And so prednisone, again, 40 to 60 milligrams PO. You might give Solumedrol IM. You could give dexamethasone. There are studies in the national guidelines looking at giving high-dose inhaled steroids, so 3 milligrams of fluticasone per hour over 3 hours, and that may, but that's a lot of puffs of fluticasone, but that may help these patients. I don't particularly do that. Not a lot of data behind it, but it's another option. So this patient gets 2 duonebs, meaning albuterol and ipratropium back to back, and she's given Solumedrol. So adding anticholinergic therapy to your beta agonist has additional bronchodilatations, and those patients with severe bronchospasm. So most of the studies look at patients coming in with a FEV1 less than 30% of predicted. They have severe, they're in distress, they've been having symptoms more than 24 hours, and so it looks like if you give this to them, it increases their FEV1, improves their outcome, and decreases their hospitalization. And it's really not a major role in outpatient therapy, nor inpatient after the ED course. You lose some of that effect by about 48 hours. Looking at the role of anticholinergics in asthma, that's kind of what is undergoing now, some national trials looking at long-acting anticholinergics in asthma. But, the short-actings, we use them occasionally, but it's not, I would say, the preferred treatment. But I do have some patients that can't take albuterol because of jitteriness, and so we have tried to use some anticholinergics. So steroid therapy, we've already talked about this. So here's our patient. She got 2 duonebs, she got her steroids, and now she's still tachycardic, still hypertensive. Respiratory rate's a little faster, but she's not speaking. So that's a big flag, right? So she can follow some commands, is working hard, and just decreased breath sounds in all lung fields. So if you're giving, you've given your nebulizers, you've given your steroids, so what other things can you use to help this patient? And there are other medications in the emergency setting, and maybe even in a school setting. So epi, there are... giving 0.3 milligram, and again, this is adult dosing, sub-Q, you could give it every 20 minutes times 3. You could give terbutaline, sub-Q every 20 minutes times 3. You want to make sure that these patients really are having asthma if you're giving epi, because it does induce tachycardia. It also can induce VTAC. So ventricular tachycardia, I had a couple patients that went into for a couple minutes, and then I had my own ventricular tachycardia as I was watching them. And you want to make sure they're not having an MI, because that's not really the best treatment. Magnesium, we'll talk a little bit more. There are studies looking at leukotriene modifiers. So zafirlukast at a high dose, 160 milligrams. Or there were studies looking at montelukast given IV. Now, that is not available. We only have the oral agents, but 7 versus 14 milligrams. And if you gave this within the 2-hour window, patients had improved FEV1 and etc. So not really ready for prime time. And if you give an oral agent, it's going to take probably about 90 minutes to work anyway. So won't hurt, but may not help. There are helium-oxygen mixtures that are in the emergency departments that have been given to kind of decrease the viscosity of the inhaled air and reduce work of breathing. I don't really think they are important this is important in asthma, but there are studies that looking at giving nebulizer treatments, the albuterol nebulizer treatments through a heliox delivery. So we have 70% and 30% helium oxygen mixtures. There are also 80 and 20. 80% helium, 20% oxygen, so maybe helps deliver the albuterol droplets deeper in the alveoli to help with the turbulent airflow. So the effect you see with this is within the first hour, that maybe they feel better, but there's no really important outcomes, so it doesn't decrease hospitalization, it doesn't decrease risk of intubation. So I don't really believe in using it, and I think it's more for upper airway problems like epiglottitis and things like that. BiPAP also has been used to decrease work of breathing in your patient with severe asthma. Obviously, you don't want to use it in people that have already altered mental status. So, I don't. We do use BiPAP as a non-invasive ventilation for some patients. So, IV magnesium, how does it work? Well, it interferes with calcium. Mediated smooth muscle contraction. And when you look at patients that present with asthma, about half of them could be hypomagnesiemic, so that's how the thought process started. There were many uncontrolled trials suggesting a benefit, but the meta-analysis in 2005 showed that if you gave 2 grams to conventional therapy, IV, it reduced hospitalization rate in patients in the emergency department with severe exacerbation. There's really not proof that it helps the patients in mild or even moderate exacerbation, but in patients with severe exacerbation, it may help. There's a randomized controlled trial on children showing substantial improvement in their peak flow in the first 2 hours after a single 2-gram bolus. So I use it. It's not going to hurt. Again, it helps in the severe exacerbation group. So if you've seen someone in an emergency setting, and if you've gotten a peak flow measurement on them, there are algorithms in the national guidelines. So a good response, if their peak flow is greater than 70% of what it should be, you probably could discharge these folks on oral steroid bursts with follow-up in 1 to 2 weeks. And that's the key point. So if you need to follow these folks up after their exacerbation, and the ideal time frame is within 2 weeks, because they are at risk of relapse. And we talked about those patients that are on oral steroid taper. Maybe we haven't treated their inflammation well enough. You want to make sure that everything is going well. If they've had an incomplete response by your treatment in the urgent or emergent setting, you're probably going to hospitalize these versus putting them in an observation unit in the emergency department. And that can be a peak flow personal best between 50 and less than 70% of their predicted. And if they've had a really poor response, obviously you're going to hospitalize these folks, and whether you put them in the ward or the ICU. So I wanted to talk briefly also about what we're doing now. We have a post-emergency department clinic that we've created a team of respiratory therapists and certified asthma educators to manage patients that present with asthma exacerbations. So we have a core group in the adult ER of respiratory therapists. So they've actually undergone an enhanced education and training. They are not necessarily certified asthma educators, but we've got a program for them to give consistent care and consistent management. So our bronchodilator protocol, our education for them that they get in the ER. We know that giving education to asthmatics in the ER isn't as effective because they're in extremis, but it may help a little bit. So we give them a little bit of education, and then this group of respiratory therapists in the emergency department refer these patients to the asthma self-management and education clinic that is also run by our respiratory therapists that are asthma educators. So they're registered respiratory therapists, they have asthma certification, and they staff these visits. So it's a 1-to-1 clinic visit. So they make an appointment from the respiratory therapists that see them in the emergency department to this asthma education clinic. And the patients, we've lengthened it out to 2 to 3 weeks after their ER visits. So that then they are seen by this the clinic. They get spirometry, they get education, they get an emergency action plan that is given to them. And then what we also have seen are these patients' 30-day readmission rates for ER visits. So percentage of patients that are readmitted to the ER within 30 days, if they are not seen by the core respiratory therapists in the ER, it's about a 22% revisit for asthma to the emergency department. if they are seen by the core respiratory therapist and given our protocol and appointment set up, then it's only about a 16 or 17% readmission rate. So they got a little bit of education and reinforced to either go see their doc or make sure they have meds. If they were seen by the respiratory care people and seen in the asthma education clinic, there is a 6% readmission rate within 30 days. So we can show, and these are small numbers, and first year of looking at this, we can see that if they are sent to this asthma education clinic where these appointments are like an hour and a half long, where they get a lot of education, they get spirometry, and they make sure they get the appropriate medications and they're on the right treatment, we can decrease their admission rate. The other thing I want to mention about our asthma education clinic, so what we do is we support these folks. So many times patients come to the emergency department and they're not prescribed inhaled steroid. They're just given oral steroids and an albuterol inhaler and say, hey, go ahead, find your doc. Well, we're trying to also change mentality in the emergency department to get the emergency department providers to prescribe inhaled steroids. This is out of their mindset because they don't follow these patients up and they don't usually give them prescriptions for control of medications, but we're trying to work with them on that because we know if the patients get put on appropriate therapy, they're going to decrease their exacerbation rate in going back to the emergency department. So one of the things that we do in this asthma education clinic is if the patients are seen and they are not prescribed controller meds, then they call me. The respiratory therapist calls me or one of our pulmonary fellows and says, hey, we are seeing this patient. They have moderate persistent disease. They're having a lot of symptoms. We think we should jump to a combination product or we should just at least give inhaled steroids. Could you send a prescription to their pharmacy and see if they can be placed on controller therapy? And then they are either seen back at the asthma education clinic if they need more education. They're made sure they try to get an appointment with their primary, or if they have really bad disease and frequent visits, then they'll send them to us in pulmonary. When you're looking at patients that have been hospitalized for asthma, in-hospital mortality overall, thank goodness, is decreasing. When you look at it before the 90s, about 38% mortality in adults that got ventilated. Now it's down to 7% or so. Intubation is the strongest risk factor for risk of death from asthma. And what's interesting is when you look at patients that have been admitted to the ICU and been on a ventilator, they have an estimated mortality from recurrent attacks 10 to 25% over the subsequent decade. So that's really an impressive number. So you really have to take intubation and being on a ventilator as a very severe disease marker. These are your websites for your guidelines for asthma. And then, of course, the CDC has information. The NHLBI website does have patient information too, which is always helpful. So education really is the key. I think we've done a lot of work to try to decrease recurrent ER visits. I think that's going to be important with our Affordable Healthcare Acts and trying to come up with some other thing to help decrease ER visits when we are overloaded in pulmonary, when primary care, we can't find primary care providers. We developed this respiratory therapy run asthma education and self-management clinic that has, in small groups, decreased the ER visit rate and gotten people on appropriate controller therapy so that they don't bounce back again and again and again. And then trying to get them access to a provider. And if it's going to take a while to get to a provider, they see them again in the asthma education clinic. And they're also starting to bill for them. So that's a good thing. They're seen as providers in our institution, and they can submit bills for asthma education. And that is all I have. If there are questions.
Michael Lentz, ABQ Health Partners.
Hi.
Hey, hi, thanks for the talk. What's your dedicated phone line for providers?
So our for if you need to call us, it's through the PALS line, 272-2000.
That's how I got it.
Yeah. to talk to whomever in pulmonary. If the patients, unfortunately, I'll tell you the sad truth is the clinic decided to dismantle our patient phone line that was dedicated. So now it's a phone tree, unfortunately. So what I tell my patients to do is they call our asthma clinic phone number, which is 272-3840. I tell them to insist to speak to me and get the message to me. So then it gets put through the phone triage, and then it comes to me in our EMR as a message. But again, it may not be right then when they need it. Our MIAs and our nurses will triage these calls still, fortunately. And if it sounds like the patient's really having problems, they text page us so that we can call them back and figure out what to do. So unfortunately, our nice phone line for our asthma patients was taken away. But now they call through the phone tree, and then the MAs fortunately still text page us with the urgent issues, so that we try to still prevent them from going to the ER. So we'd rather see them urgently if we can, or start a burst of prednisone over the phone, or figure out what their issue is to try to keep them from going to the emergency department.
And for the pediatric patients, they would call the PEDS pulmonary number, which is 272-5464, and during office hours will be transferred to a nurse who will again triage and try and troubleshoot that way. And after hours, they call again the PEDS pulmonary number, and they will get transferred to whoever the pediatric pulmonologist is on call.
Nice.
Okay, thank you. One other question, if I may. For us that are trying to do more of this in primary care, it certainly is an art on how to interpret the patient and the history and the pulmonary function test. Nothing seems to be clear. Is there a way that we set up some type of an overread system with our institutions to kind of review pulmonary function tests until I can be better at interpreting these? So that's the question.
I mean, I think it would be reasonable if you wanted to maybe fax them here to Envision, and they can be looked at. I'm always happy to review PFTs. I have some folks up in the Raton area that, again, they're respiratory therapists, and they're learning the whole thing on how to do PFTs, and they ask for my interpretation a lot of times. So they'll PDF a copy of it to me through my GroupWise account, and I'll look at it and kind of give them my interpretation. Yes, this was a good test, or, this actually wasn't a good test, so I wouldn't necessarily make a lot of treatment changes off of this. So there's that way that I've had people email me PFTs, but I think it might be reasonable to review them here. If, then maybe they could be scanned in and other people could review them as well. I don't know, Francine, if you can do it in a more real-time fashion. Is that also what you're looking at, is in a more real-time fashion rather?
Yeah, that'd be great. Sometimes it'd be great, but again, a lot of these patients I've sent away. In fact, I called pulmonary last week, and they're very helpful. Real time is wonderful, but sometimes it just is the art of reading them and interpreting them. And so both are great, but I'm not sure the logistics of doing that, I guess.
I guess for now, probably through Envision would be one way. If it's a more kind of urgent question, then probably calling the PEDS pulmonologist on call and making arrangements to get the results either faxed or emailed is probably the best way to go.
And there could be a session on PFTs here to put them up and kind of everybody could review. Yeah, might be. And faxing them here versus.
So if I wanted to do that, say I have a couple that are just hanging on here, and I'm thinking about, I would fax them. Is there a fax number that I can send to you, and then you'd get back, or you'd call me, or I'd call you, or how?
Through the Envision system or directly?
Well, I guess what you were advising is through the Envision system, or whichever works. I mean, these aren't urgent right now. Just what is the fax number that I could probably contact someone and have them review?
Okay. Kevin's going to get that for us.
Yeah, hi, this is Kevin from Envision. So the fax number here is 925-7601. 925-7601. And just make sure to, I don't know, how would you like to have them addressed? Or just have your name on them?
Maybe just put my name on them, and of course be sure to block out any patient-sensitive
Info.
info.
And then asthma clinic or asthma
Right.
telehealth with
Or
Dr.
asthma,
Cathy.
or put asthma telehealth
APT
or
or-
APT, so they just know where to direct it, and then we can look at it either as a group, or I can try and look at it and get it back to you within a few days.
That'd be great. Thank you.
Sure.
This is Alice Marosi, and I would like CME, please. And I would like to ask Michelle,
Yes.
can you hear me? Okay.
Yes.
I would like to ask you this. Years ago, there were some studies on adding ipratropium to albuterol naps, and what the outcome was that you had to do 3 treatments 20 minutes apart
Right.
before it becomes, a significant thing. Is it same in
Yeah.
adults? Okay.
Yes,
And
and
the
that-
other, yeah?
Go ahead.
Oh, and the other comment I have is that recently I've seen some studies on the Xolair that actually even patients who have non-allergic asthma and patients with severe asthma have responded favorably to that treatment.
Yeah, so I think our protocol we do for adults too is just, they pretty much get the ipratropium all three, unless it's, someone they don't really think is having bad. But yes, having all three of them does improve their hospitalization and symptoms in adults as well. And I have not seen the study looking at the Xolair and the non-allergic asthma. I mean, I do have a couple folks that I'm trying to put on it that may fit in that non-allergic asthma, and I'll see my N of a few to see if it helps. But it is another treatment modality. The other thing that we're starting is bronchothermoplasty at the university. We've got 6 folks lined up, and I think we've done our first person. Who thus far seems to think it's helped. So that's basically, for those that aren't familiar, that's radio frequency ablation of the airways, basically under a bronchoscopy, under 3 treatment sessions. And I don't know, I think it's a little voodoo personally, but it helps in theory to decrease the smooth muscle mass that's causing bronchoconstriction and other symptoms of asthma. So that's the other new thing that we're doing. At the university, we have a procedure clinic that we've set up to start seeing some folks that might be, that have poorly controlled asthma, they have a low asthma control test score, they're on maximum medical therapy, and we really think it's asthma and not something else. And other issues have been resolved. So that's kind of our new thing that we're doing now.
And I should have started with it that it's been an excellent presentation and that I enjoyed it always.
Oh, thank you.
I should give you a bottle of wine.
Ah, I love it. Thank you. Other questions,
Hello?
concerns?
Hello,
Yes.
this is Eldine Domer, and could I get an attendance certificate?
Absolutely.
Do you need anything more other than I'm from Rio Rancho? Do you need my
No, I think they
email?
have your information, right?
We do
Kevin?
have your information. This is Kevin at Envision, and those are sent out on a quarterly basis.
Okay.
So at the quarter, Clancy Tarbox will be sending those out to you.
Okay. You do? Did you say you do have my email address, or however you send it out?
I do. Yeah, we have your AOL account on file. It's when you registered for the session.
Yes. Yes.
We have all that information now.
Okay. And I'm also registered for your Friday go-to-meeting class, and so I I would like to be sure that I get the 2 attendance certificates, or just ask
Absolutely.
again. Okay.
Sounds
Thank
good.
you
Yeah,
so
just
much.
be
I
sure
do.
to. I'm sorry. Just be sure to announce your name at some point during
Okay.
the webinar.
I will do that, and I thank you so much for all your webinars.
Well, thank
We
you
also
for
have
coming.
After Hours Pediatrics, Nicole Vega, Joanna Stagner, and Deborah Roberts.
Okay. I will be looking at your calendar, I believe you have, and checking on the things that I would like to get more information on. So thank you again.
Okay. Great. Thanks, Joanna. Stagner. She listed a few folks.
Nicole Vega.
Right, Joanna, Nicole, and Deborah, right?
Yeah. Yep. All right. Other questions, issues, concerns?
Yes, hello. I just want to say
Yeah.
hello. This is Hangame.
Hey, Hangame.
Sorry I missed you guys.
Oh, no worries. All right.
All right. Is there anybody that we have missed or has not yet announced that they had signed in?
Hello?
Hi.
Hi, Raquel Vandenbout
Okay.
from BCA Medical Pediatrics. I'm an asthma educator.
Oh, great.
Great.
Okay.
Oh, from Roswell.
Thank you
Fabulous.
for
Maybe you
letting
can
us know.
start an asthma education clinic down there
There you go.
to get them out of the ER.
Yeah. Well, we actually don't have too many moderate or severe asthmatics. The majority are intermittent, thankfully.
Thankfully.
Oh, that's good.
Yeah. But still, they need education and they can have a bad attack too. But yeah, that's good. That and I, honestly, some of these folks that were these frequent flyers that kind of came through the emergency department really didn't have that bad asthma. It's just they didn't have the right meds. They didn't understand their disease. They didn't have anybody to contact, and so they were flying into the emergency department all the time. So once we set them up with education, make sure they were on appropriate therapy, and had someone that they could contact, that's what really made the big. I think having our asthma educator that they could contact was the biggest reason for success in our clinic. Just because patients, needed someone to run things by or make sure there's not an issue. So, and then making sure they're on the appropriate therapy and that they're taking them correctly. So that's the biggest thing I think for us that was our success. But good luck.
Thank you.
All right.
All right. Well, thanks everybody for listening and signing in, and thank you, Michelle, for an excellent talk. And our next session will be in December, and will be planned follow-up visits in the outpatient setting, and we'll talk a little bit more about kind of what to do for planned visits, follow-up visits. So if you have any ideas that you would also like to add that have been successful in your practice, please email me or email Kevin and let us know, and we'll be sure to try and include them. Thank you. Have a good week.
Thank you.
Bye-bye.